Hello everyone. Today our topic for discussion is hypokalemia. It is a very important topic and unfortunately in the standard textbook, hypokalemia topic is given in a very complicated and complex form. So this topic will try to make it simple with the help of some diagrams and flow charts. It will be useful not only for the MBBS students but also for medicine residents, senior residents and general practitioners. If a patient of low potassium is coming to you, how to approach. We'll discuss what are the causes of hypokalemia, clinical features, approach and management with the help of some clinical cases. So starting with the causes. So what exactly are the causes? We'll try to understand with the help of this diagram. Say this is a GIT tract. So this is the GIT tract, and whatever food we take contain potassium. So potassium is in the diet. So the first cause of low potassium can be decrease intake of potassium. So decrease intake of potassium. So that can be starvation or clay intake. Starvation or clay intake. Clay intake bind the potassium. Then this is the blood vessel. So this is a blood vessel and this is a cell. So the second cause here will be potassium. Potassium is in the blood vessel. So it could be a redistribution. Second cause is redistribution into the cells. So this potassium will be going into the cells intracellularly, so making the blood potassium low. So what exactly will be the causes? The cause number one for redistribution. So the cause number one can be metabolic alkalosis directly. So why metabolic alkalosis? Because H plus is low in metabolic alkalosis in the blood. So what cells will do? Cells will release their H plus, but in exchange they will take K plus inside them. So first cause is metabolic alkalosis. Second cause. The second cause is some hormones or drugs like insulin. Insulin has a property that it leads to the potassium uptake into the cell within minutes, and the same property is with beta agonists like salbutamol has the same effect. Theophylline. So how does theophylline work? Theophylline will work here like this is sodium potassium ATPase. So what does sodium potassium ATPase does? Sodium ATPase brings the 3 sodium out and 2 potassium in. So theophylline stimulate this channel or stimulate this ATPase. So more potassium will go inside the cells from the blood. So theophylline, and similar action is with caffeine intake. While sympathomimetic effects of the body will also lead to the potassium entry into the cells, sympathomimetic actions. Then some toxins like barium leads to intracellular shift of the potassium, Now the third cause in this list, that is redistribution. First was metabolic alkalosis, second is drugs or the hormones, and the third cause will be anabolic states. Anabolic state means that there is example increased RBC production due to say we have given B12, we have given folic acid in B12 and folic acid deficiency. So RBC production increase. So RBC will take up more potassium they are potassium is intracellular, more RBC, so they will take up potassium inside them, and that can lead to the hypokalemia. Patient can die also. Therefore, it is very important to monitor the potassium levels during the supplementation of B12 deficiency, especially if it was chronic. Now, the third cause of low potassium is the increased loss. Now, increased loss can be due to non-renal causes. Non-renal causes. Non-renal causes can be through GIT. Through GIT means vomiting, potassium is lost, or through diarrhea, or it can be through skin, sweat. So these are the causes of non-renal. Now the number 2 is the renal causes. This is more important for us. Renal causes. So how the renal cause leads to the potassium? So this is a tubule. For example, this is tubule. So in the tubule there is a channel known as E-sodium channel, and E-sodium channel is under the influence of aldosterone. This is under the influence of aldosterone. So the function is to absorb the sodium. So if the sodium is absorbed here, so lumen become more negative. As a result, K plus is excreted out. Yes, there will be release of the H plus also. So this is due to the effect of the aldosterone, that E-sodium channel is activated, and negative charge inside the tubules leads to the excretion of potassium, as well as there is one more channel which is known as RO, renal outer medullary potassium channel. Renal outer medullary potassium channel. So the role of this is the potassium excretion into the tubules, and normally this channel is inhibited by magnesium. Normally this channel is inhibited by magnesium. So normal magnesium level will inhibit this channel, and potassium excretion is reduced. Therefore, if there is a magnesium deficiency, potassium excretion will increase, because this channel is not inhibited. So it will lead to excretion of more and more of potassium here. So based on this, let's see what will be the renal causes. The renal cause will be divided as, starting from the simple one, low magnesium. Low magnesium, yes, whenever a patient of low potassium come to you, always check the magnesium level in that patient. Second cause can be increase in aldosterone levels. Increase aldosterone. So aldosterone is high, so there will be more potassium and H plus release. High aldosterone level can be high because of the primary hyperaldosteronism, or it could be because of secondary hyperaldosteronism. So it can be a primary or it can be secondary. Primary means that adrenal gland is stimulated, it has adenoma like Conn syndrome. Secondary can be because of high renin, so renin releasing tumors, or it can be because of renal artery stenosis, that renal renin is stimulated, that in turn lead to high aldosterone. Other cause of the secondary hyperaldosteronism is volume loss. So in the volume loss, RAS activated, so renin high and aldosterone high. So those will be the causes here. While it can also be because of the activating mutation of the sodium channel, so E-sodium channel mutation, and that is activated mutation known as Liddle syndrome. Liddle syndrome. Or it could be a syndrome of apparent mineralocorticoid excess. Same syndrome of mineralocorticoid excess. That means ki there is a deficiency or inhibition of beta hydroxy dehydroxysteroid dehydrogenase DHS, sorry, dehydrosteroid dehydrogenase. So this is deficient. So the function of this enzyme is it convert the cortisol into cortisone, but if it is inhibited, cortisol level will increase. So cortisol level will increase, and cortisol has a mineralocorticoid like action, so aldosterone activity will be more. Aldosterone activity will be more here. So these are the causes, renal causes, which leads to the hypokalemia. Now, let's revise them one by one. Decrease intake, redistribution to the cells, non-renal loss, renal loss. Increase hyperaldosteronism can be primary. Primary means like Conn's syndrome. So we'll revise once again. Conn's syndrome. It is uh, adenoma, adrenal adenoma. So in this condition, what will happen? Aldosterone is high, and because of the aldosterone elevation, there will be a negative feedback on renin. So renin level will be reduced because aldosterone is high. While in secondary causes, the main reason is high renin activity. So high renin is leading to high aldosterone. So that can be because of renin tumors. It can be because of renal artery stenosis. In both the condition, blood pressure will be high. But in other causes like volume loss, ECA volume loss, like Bartter syndrome, Gitelman syndrome, there is inhibition of sodium channels. So sodium loss, water loss, that in turn stimulate renin, and renin will stimulate the aldosterone. But very important to know that in these conditions, blood pressure will not be high. Apparent mineralocorticoid excess. So this was a stimulating mutation of E sodium channel, and Liddle syndrome was one of the cause, Liddle syndrome. Or it could be a inhibition of 11 beta steroid dehydrogenase. So cortisol level will increase. Cortisol as a mineralocorticoid like activity. Now it could be a distal anion delivery. Distal anion delivery can be like this, कि if the negative charge are more in the distal part, so because of the more negative charge, where they are coming from? They are coming from the glomeruli. So the K plus will be released more and more to balance the negative charge inside. So this condition, distal anion delivery, will be because of penicillin. Penicillin is negatively charged. It could be acetate in diabetes ketoacidosis, or it could be bicarb in cases of renal tubular acidosis, especially type 2. So bicarb is not absorbed, it will go to the distal site, and it will lead to the excretion of potassium. And low magnesium because of increased activity of ROMK channel, that lead to the excretion of potassium. So these are the causes here, and you should be knowing ki how to approach these clinical cases. So first look at the clinical feature of low potassium. So the clinical feature of the low potassium is mainly due to more negative resting membrane potential. So suppose for example, this is a cardiac muscle, this is a resting membrane potential negative. So what happens that this is potassium inside the cell, this is the cell, and if the serum potassium is low, what will happen? This potassium will move out more and more. So if the potassium is moving out more and more, the resting membrane potential become more negative. Cell is more negative inside. Negative charge will increase more inside, so the muscle become less excitable. RMP is low, so muscle excitability will reduce. So this is the main basis of these clinical features here. So the clinical features will be all muscles, whether it is a skeletal muscle, paralysis can occur, like hypokalemic periodic paralysis can be there. It can be smooth muscles of intestine. This leads to paralytic ileus. It can be cardiac muscles. AV blocks can be present. AV blocks will be present here. And these are the classical changes of the ECG, so which you can see here in the ECG. ST segment. So this is an important question for the MBBS student also, NEET PG aspirant also. ST segment depression is there. T wave inversion is present. You can very well see here. And most important is the U wave become more prominent. U prominent. Remember, QRS remains normal and sometimes QT interval prolonged, and that lead to torsades de pointis. Torsades de pointis. Important ECG changes of the low potassium. So here you can see that patient was having this T inversion was there, U wave was prominent. So there were changes were present here, and suddenly patient develop arrhythmia, torsades de pointis, increasing decreasing trend of the QRS complex is there, while the kidneys will be affected in cases of hypokalemia in multiple ways, like nephrogenic DI. Reason, it inhibits the ADH action on the kidney tubule. Low potassium inhibit the ADH action. There can be a vacuolizing injury to tubules, renal tubules. Renal cyst can be present due to low potassium. These are the effect, functional effect and structural effect on the kidney due to low potassium. Now the approach to a patient of low potassium. So whenever a patient of low potassium comes to you, you should rule out 1 and 2 cause. 1 and 2 cause was rule out low intake and redistribution. With history, redistribution history, like insulin, beta agonist, barium exposure, like that. So these has to be ruled out, and if these things are ruled out, look for the urine potassium. Urine potassium will take in millimoles per day. So two results: if urine potassium is less than 15, it is going less, so it is a non-renal cause. It is a non-renal cause of potassium loss. So what are the non-renal cause of potassium loss? You can see in this diagram. Loss, non-renal cause, vomiting, diarrhea, skin, sweating. So these are the causes, non-renal causes. So they will be apparent on the clinical history, but if clinical history is not given, then look at the arterial pH. So if the arterial pH is high, that means alkalosis. So you can say why alkalosis will occur: due to vomiting, HCl loss. Arterial pH is low, acidosis. This will be due to diarrhea. If arterial pH is normal, it is sweating, because in the sweating pH does not change. A very simplified approach will be here. And if the potassium in the urine is more than 15, then it is a renal cause. So what are the renal causes? Let's see, these are the renal causes here. So renal loss of potassium, it can be increased aldosterone, in which primary will be there, primary hypertension is present, renin level will be reduced by negative feedback. Secondary causes, renin levels are high, and it will be hypertensive state like renin tumor or renal artery stenosis, or hypotensive state like volume loss. It could be apparent mineralocorticoid excess like Liddle syndrome, or congenital syndrome like SAME, syndrome of apparent mineralocorticoid excess, or it can be a distal delivery of these anions, or it could be low magnesium. So let's see how to rule them out. So we will look at the blood pressure. This is the most important parameter to be assessed. So if the blood pressure is low, so there will be important causes ki why blood pressure is low. We will go for the arterial pH. So in cases of the low blood pressure is there in conditions of Bartter and Gitelman. In Bartter and Gitelman, sodium channel are inhibited, mutation is loss of function, sodium loss occur, water loss occur, ECA volume become low. That in turn stimulate the renin angiotensin system. So because of the high aldosterone, more potassium loss, more H plus loss will occur, alkalosis will develop because of the high aldosterone level. While in cases of diabetic ketoacidosis, renal tubular acidosis, pH will be acidic. These are acidosis conditions. So arterial pH, if it is low, think of DKA or renal tubular acidosis. If the arterial pH is high, it is Bartter or Gitelman syndrome. While if the blood pressure is high, then we have to look for the aldosterone levels. If the aldosterone level is high, that means it is a case of primary aldosteronism, renal artery stenosis, renin tumors. While if the aldosterone levels are low, so that means it is a case of a apparent mineralocorticoid excess. Like aldosterone is not high, but E sodium channel is working more. So ECF volume is high, it will lead to low aldosterone level. So low aldosterone level are due to the response of high ECF volume. Problem is starting from here, that is inhibiting the aldosterone levels. So these conditions are Liddle's and SAME, syndrome of apparent mineralocorticoid excess, because the problem start from the high ECF volume. So this is a simplified flow chart ki how to approach. Now let's see some clinical cases. Before the clinical cases, let's see the treatment first, and then we go for those options, the clinical case scenarios. So the treatment options. So the treatment option is if high potassium is due to low potassium is due to increase sympathetic activity like beta agonist, thyrotoxicosis. So here you give propranolol. If it is due to the increased sympathetic stimulation. While if patient has number 2, depending on the potassium levels, so the potassium levels are less than 2.5, which is a severe low potassium and or ECG changes or emergency like paralytic ileus is present. In that case, we will give IVKCL. Now, how to give IVKCL? It is given as an infusion 10 to 20 millimoles per hour. It should be given. And very important, after 40 millimoles has been given, check the potassium level. If the potassium level you are giving 20 millimole or more than 20 millimoles, give it through a central vein. Central line you have to give, and it should be given in saline, not in dextrose, not in the dextrose. And if the serum potassium is say between 2.5 to 3.5 and a patient is asymptomatic, then oral KCL will be given. Oral KCL is pot chlor, which all of you know, which contain 50 ml contain 20 millimoles. So when we are giving oral KCL, we give 20 to 40 millimoles per day in divided doses. In divided doses like 15 ml in the morning, 15 ml in the evening, with 1 glass of water, and that should be with meals or just after meals to prevent the gastric irritation. While if here we can write it as 2.5 to 3.5 and mild symptoms are there, mild symptoms, no ECG changes, then this will be given. While if the potassium is in this range 2.5 to 3.5 and patient is asymptomatic, so treat the cause. So you can make a correction here. When the potassium is 3.5 to 5.5 and patient is having mild symptom, then go for oral replacement. If 2.5 to 3.5 and patient is asymptomatic, so after treating the cause, we can treat the potassium levels here. So let's see with the help of this protocol. Clinical case number one, patient is 60-year-old male on thiazide diuretic. Thiazide diuretic loss cause potassium loss. Potassium is 3.3, normal potassium 3.5 to 5.5. Patient is asymptomatic, ECG normal. What you should be giving? So you stop thiazides when we have a underlying cause here. So that should be treated. That should be treated here. Clinical case 2, 45-year-old female, vomiting is present, and potassium is 2.7. Potassium is 2.7 and ECG is normal, and a patient has mild symptoms, for example. So in that case, what should be done? If patient is not accepting orally, then we have to go for a IVKCL, because vomiting is present, not able to accept orally. Even if the symptoms are mild, ECG is normal, so we have to replace the potassium here. Now, patient has weakness, patient is taking insulin, and potassium is 2.2. And when the potassium is less than 2.2, definitely IV KCl has to be given. And here you can see ECG changes are there. U waves are prominent, T wave is inverted. So give IV calcium chloride in this scenario. Now, tell me what will be your diagnosis here. 24-year-old male, weakness is present, BP is high, renal artery bruit, and potassium is 2.4. What do you think will be the cause of this low potassium, and what should be the treatment in this condition? So, put your answer in the comment section. Let me see how you can solve this case for me. So these are the approaches to a case of low potassium. If you have any doubt, question, you can put in the comment section. Thank you.